Okay. So we're gonna do chapter 30. We said, I think I said 35 and 36. Just the three chapters that are here.
So 30 and 36.
Yes,
I'm not sure if 35 is included yet.
okay, so we could skip over it if you don't want to go over it.
Okay. No, we're doing it coming, but if you want to do it, that's fine.
Okay, I'll do it just so that you
Okay.
guys have it, but it's probably like a 20 slide thing. I think she asked like one or two things from here, but she does ask about something on here, and I think it's just
Okay.
like how to give
Okay,
it.
you could go over those three chapters then. That way
Okay.
we have an idea of what she's gonna when she go over it, we understand it more.
Yeah. Okay. But I hope your clinicals and everything's going well. I loved my OB clinical more than pediatrics, don't know why. I just
True, true.
I liked it a little more. I don't know, between the two of them, I had to say I liked OB. Thought it was kind of cool. Um, but now we're in peds, so we're gonna talk about a traumatic care of a child. Let me just open these notes fully so I could see it a little better. Okay. So, a traumatic care of the child. So, a traumatic care basically means that we want to do a type of care that minimizes and eliminates any sort of physiological and physical distress that a child and their family can experience. Think about a traumatic. We don't want to cause trauma to this child and their family. So there's different ways that we could do that. And we could first prevent or minimize physical stressors. So this includes, right, no intrusive or painful procedures if they're not necessary. So minimizing the use of injections, punctures, catheterizations, things like that. Um, we also want to make sure that we avoid any sorts of physical distress, such as loud noises. We reduce, nausea, vomiting that they could experience. If they have sleeplessness, we don't want to use restraints, all that stuff. Remember, think about no harm, and we want to do the least amount of things that we can that can cause stress, right? So, injections or anything invasive is stressful, right? Loud noises, feelings of discomfort, that's a distress. Therapeutic hugging is a way to help reduce stressors. Pain control is really good during the use of frequent assessments and using pharmacological or non-pharmacological interventions, something like Elma cream. So that could be good to help numb certain areas, especially like maybe if you're going to give an injection, maybe put a little cream on there, that way you could help numb the area, or if you're going to do something that could hurt. Things like that. And always advocate for minimal laboratory blood draws. So, for example, if the doctor orders to do a blood draw at 12 and at 1 ask the doctor, "Hey, can I do this all at 12 because I don't want to keep sticking my patient?" And things like that. The next thing that we can do to promote atraumatic care is to prevent or minimize child and family separation. We want to make sure that the family is always involved in the care and treat the family as the patient. So, have an environment where the parents can either stay over or just have lots of exposure time with their child. Um, Make sure that we also we consider using research findings that relate to the preferences of the parent and children. Um, and things like that. Um, the next thing that we can also do is we want to make sure that we promote a sense of control, right? That we need to make sure that the family also feels like they have a say and that the child also knows what's going on, right? You're in a new setting and all of this can be a lot. So we want to make sure that we elicit the family's knowledge about the child and his or her health condition and promote partnerships, empowerment, and enabling. Make sure that we get them to understand everything that's going on with the child and also explain it to the child, right? You might not be able to explain everything to a 3-year-old, but tell them, okay, like, I'm going to give you a little pinch right now, okay? We want to check to see if everything's okay. Like, we still want to tell them to a child, right? Because they still are the patient. We also want to reduce fear of the unknown through education, and decreasing threats in the environment. We want to make sure that we explain everything to them, and we want to provide opportunities of control, especially for the child, such as a way to participate in the care. Maybe ask a 3-year-old, do you want to hold this? Like if you gave them a little prick, or, maybe tell them, hey, like you want to put the band aid on, like things like that. And we also want to have a daily schedule and have direct suggestions, because especially for children, they need to have a normalized schedule. Children usually follow a routine at home, and they should have a routine here as well. We also want to mimic words that the child uses. That's going to really help with the child feeling comfortable and making sure that they're not feeling like you know, like they're not in their home environment, because that can cause distress. And choices are really important to toddlers and preschoolers, right? Such as, hey, what kind of band-aid would you want, right? All of that's really important. This is just a chart that I found in the textbook that just reiterates everything that I said, but you could find this table 30.1 to like further see more like suggestions for atraumatic care. There's also child life specialists, which they help understand the developmental impact of illness, injury, trauma on children. They provide programs to help prepare children for surgery and procedures, and they even help with coping skills. Now, just an emphasis that child life specialist does not just have to be for little kids. Um, Grown adults can have a child life specialist, especially if they're developmentally delayed. I had a patient when I worked in my externship where they had like developmental delays, and as a result, they had a child life specialist who would come in and help explain things like procedures and stuff to them, because the way that they would react to hearing information were of that of a younger developmental age than their actual um, real age. We also want family-centered care. We want to define first what the definition of family looks like who they live with, who takes care of the child, right? What is the relationship between the child, the family, and the health care providers, right? We want to promote trust, and we want to make sure that we understand the dynamics and we respect those dynamics of the family. Now, we're going to talk about communication techniques across the age groups, okay? So, first of all, we need to be honest when we don't know something. That's going to enhance the child's outcomes. We want to be honest. If we don't know something, we're going to find the answer. We want to make sure that we increase a child and family satisfaction, and we want to promote a therapeutic relationship. And we do this by understanding the language of the parents, by asking them, what are some words that you use at home, right? Knowing the name of their toys. If they have a comfort toy that they sleep with, they call it Baba. We should know that, so that we can promote comfort for the patient. We also want to communicate directly with the child, and we want to talk to them that in a way that's appropriate for their developmental age. So, um, things that are age appropriate would be warm up, right? Like making sure, you have eye level interactions. You could incorporate play with them. You could use doll, puppets, stuffed animals, depending on their age, right? You could use metaphors and stories. You could do artwork and drawing. And the older they are, like an adolescent, they're not going to want play and dolls and puppets and stuffed animals most of the time, right? If we're talking about a 16-year-old, right? So they might need more privacy and things like that. But if we're talking about an infant, 1 to 12 months, communication for this is through touch, sight, and hearing. Okay, because babies can't speak to you when they're 1 month and 12 months. So they communicate through crying, and we need to respond to crying immediately because we don't know why a baby's crying. An infant also learns through touch, and they respond to tone of voice. So all of that is very important, as well as holding the baby, rocking the baby. All of that's going to help with communication. Give time for the infant to warm up to you because they don't know you, especially if they're there for periods of time. Babies can cry more because of that. We want to use a soft and soothing, calm tone and speak, directly to an infant. And maybe communication through play could be helpful for like an older infant, like let's just say 10, 11 months, things like that. And we also want to watch for signs of overstimulation. So if a baby's closing their eyes a lot, they're turning away, they're yawning, they're irritable, that means they're overstimulated. Okay. The next thing is for toddlers. This is an age group between 1 year and 3 years. You do need to know the age groups. I'm telling you now, each group. She may even say, she's not gonna say toddler she's gonna say that this is a 2-year-old child. How should you communicate with them? So, if we're talking about a 2-year-old or a 1-year-old or 3-year-old, um, they now have more words or they're starting to form words, right? They may use a lot of words that are not real. We also want to give them choices. We said before, toddlers, ages 1 to 3, preschoolers 3 to 6, very important to have choices. So for toddlers, we want to make sure we give them choices. Like an example I said was Band-Aids, right? They love to say no, these toddlers, okay? And because they're still, just learning how to form words, let them have time to try to form their thoughts. We want them to be independent because they're toddlers, they want this independence. Um, Also, you need to approach toddlers carefully, okay? Because the problem is that they're going to be quite resistant towards you, so you want to make sure that you're approaching them in a way that facilitates a therapeutic relationship. Toddlers also enjoy things like words that they know. They like the use of objects or actions to understand. So, for example, something I've seen that's very cute is like a TikTok where a nurse comes in and she brings a bear and she shows like on the bear like what to do, where to put the band-aid, how like an IV would work, like on a little teddy bear. Things like that could actually really help with toddlers. Um, as well as using books or like telling them a story. And also, if we're going to have a procedure for a toddler, you're going to tell them right before it's going to happen that they're having a procedure because they're not going to remember if you tell them before. And this is important because I know she even did tests on this idea that if you're going to have a procedure, the toddler needs to know about it just before it's about to happen. For preschoolers, we're talking about 3 to 6 years old, right? So they'll use puppets, storytelling. You want to speak honestly. You want to use simple terms. Ask them specific questions, but they're going to be able to tell you what they want and, allow them to have appropriate choices because choices are important to them. And they also have imaginative play, right? They're in this sort of a phase where they kind of imagine things, like they're in their make-believe world, so you could use that to help explain things. And if you're going to have a procedure, you're going to prepare a preschooler 1 hour before the procedure. 1 hour for toddlers right before, for preschoolers 1 hour before. For school-age children, we're talking about 6 to 12 years of age, right? So, they're much older, so they're more interested in learning. They have more sophisticated language and critical thinking skills. So we could use things like diagrams and books and even videos, right? Allow these children to express their feelings honestly because they're able to tell you. Um, you could use third-party stories to also get information like, oh, sometimes children feel anxious about getting this procedure and things like that will help. Ask the child questions. Give them also adequate time for all questions to be answered. And if you're going to have a procedure for a school age child, you want to prepare the child a few days in advance for a procedure. So, school age, few days before, preschooler, 1 hour before, a toddler, right before. For adolescents, we're talking about ages 12 and up. So they have strong feelings and emotions that are labile, right? Labile means changing or all over the place. This is like a teenager, okay? Their emotions could be all over. They need trust and respect. We need to respect their privacy. That's very important for them. We want to be confidential and non-judgmental. We want to listen to them. We can use medical terminology as appropriate and define words because they're older, they're going to understand more things. Don't try to force a teenager to talk, that'll just make them not want to speak to you. And if you're going to prepare a procedure for adolescents, at least 1 week prior to the procedure. Other considerations are, especially with toddlers and preschoolers when it comes to actual speech, There is things that they might not understand. So for a toddler, 1 to 3 years old, or a preschooler, 3 to 6, if you say, "Oh, you're going for a CAT scan," they might say, "Where's the kitty?" Or if you say, "I'm gonna flush your IV," they might say, "IV the plant," or "Where's the potty?" Um, if we say, "Oh, the doctor will put some dye, in your IV," that they're not gonna understand what that means. A bed with wheels is a good example if you wanna talk about a stretcher. And if you said something like, "Oh, a little stick," they might turn around and say, "Where's tree?" So you need to be careful with how you say things. So there's actually a chart in your textbook. I don't know the name because I, for some reason, blotted it out. But I would know this chart because it tells you that using the word catheter is too technical. Use tube, right? Um, there's something called, if you're gonna use die, right, it could sound like death or die, so you say, "Oh, we're gonna use a special medicine to help the doctor see, let's just say, your heart better," okay? The die, we're not gonna use the word die. Electrodes, not gonna use that word. We're gonna say stickers or snaps or something like that. Um, ICU, they're gonna be like, "I see you." So just say a special room with your own nurse. So like I said, go through this chart, know what type of words to say. Another example, pain, they might not understand what that means. So you could say boo-boo or whatever the word that the child says for the word hurt. Dressing change, they're not gonna understand what that means. So you're gonna say, "I'm gonna clean your Band-Aid," or "I'm gonna give you a new Band-Aid." Um, Things like that. If you say "put to sleep," they might get confused and think of an animal. Just say you're gonna have a special kind of sleep, okay? So, like I said, read through these different things so you can understand, because she will ask you what would be, an appropriate um way to describe something to someone who is like a toddler and a preschooler, and it wouldn't be saying, "Oh, you're gonna get some electrodes put on you." No, you can't say, "Oh, incisions or holes." Think very simplistic, terms, because this is like a baby, a smaller kid. Okay. The next chapter is 35 on key pediatric nursing intervention. This is mainly has to do with like medication administration and developmental considerations. So, for medications, we're talking about rights of medication administration. And for pediatrics, this includes right medication, right patient, right time, right dose, right route, right frequency, and also the right approach. Once again, you're not going to tell a toddler, "I'm going to give you your atenolol now." You're going to say, "I'm going to give you a medication that's going to I'm going to give you something special to help your heart, okay?" Things like that, right? Um Children also are not going to really be able to self-identify. So we want to use ID bands and pictures as a form of identification. Children might not be able to say, I'm Sally Jones and I'm, you know, 4 years old. You need to have an ID band and usually pictures for children, okay? The next thing is that we're talking about our children, right? The little babies, is that children are more sensitive to medications than an adult is. And that's because they have immature organs still. And that is why it will actually affect their medication response. Children will have a higher medication response, meaning they'll have greater side effects because they have organ immaturity. Okay, so that's something else that we have to watch out for, that when we give medications to children, they have higher risks for adverse effects because they don't have mature organs, especially those kidneys, right? And the liver. And just know you never give aspirin to a child. Ever, ever, ever. Never. You never give aspirin. You never take aspirin. You never give aspirin for a kid. And that's because it can cause a really deadly syndrome, which I'm not going to get into right now, but it's called Ray's syndrome. Very deadly. No, no, no aspirin for kids. But other things that we need to consider when it comes to children is that you need to use developmentally appropriate explanations. We already talked about that, right? Especially offering choices for those toddlers and preschoolers, making sure you always involve the parents. Except maybe when we're talking about our adolescents, that could become more confusing where we involve the parents. So the thing is with pediatrics that the parents always need to be the ones that know what's going on. They have to be physically present for the care that's provided for children. We can't just do things without the parents being there. The only thing is, let's just say if we're talking about an adolescent population, if let's just say this is a 13, 14-year-old child who's pregnant, something happened like that, we are not obligated to tell the parents. That's where that could become an issue, but every other situation, we have to tell the parents. Like another example would be if they have like a sexually transmitted disease, the older child is allowed to not inform the parents of that. So, those are just two situations where like they don't have to know. Everything else has to be with the parents. That's why it says sometimes involve the parents. Now, developmental considerations. Infants need their parents, right? They know their mom, they know their dad, they know the comfort from their voice. Remember, these are babies that need touch and they respond to sounds. So we need to involve the parents and have a lot of cuddles and comfort. For toddlers 1 to 3 years old, we're talking about simple choices. They don't understand things, and there's no negotiations. It's yes or no for these kids, and that's it. Make sure that the parents are involved, administer medications promptly and reward with positive behavior. Maybe you give them a lollipop or something after they take their meds or something. I don't know. But I just give an example of a positive reward. Um, Therapeutic play with equipment. Like I said, I said, example with the teddy bear, we could show them how things are with, uh, a cute little stuffed animal. And for older toddlers, like I said, more like 2.5 to 3, we could ask them, like, what kind of band-aid do you want? Preschoolers, we're talking about, remember, 3 to 6, also simple choices. We want to involve the parents. We could have therapeutic play with the equipment. Same sorts of things with toddlers and band-aids. Same exact thing. Nothing really changes here. School age 6 to 12, right? They have a fear of loss of control, pain, and injury. We want to ask them for their input and we want to provide explanations for this group, okay? They have a fear of loss of control. That's why we need to explain everything to this group of children. Anyone who is 12 and older gets the same approach as adults, what we would do for someone as an adult. And we also need to assess developmental, physical, and motor development because we need to know, can they swallow medications? If not, we need to find another mode to give medications. Another thing is we have to have safe dosages. Um, they're based on their body weight and body surface area and maturation of the body organs. Usually the drugs are per kilogram of body weight, so the typical weight that we do or to order to, determine the right dose for a child is mg per kg per 24 hours. But weight is not generally used to compute a recommended dose once a child weighs 40 kg or more. So we usually do this for, children who weigh less than 40 kg. So the oral route is the preferred route to give children a medication, but aspiration is always a risk. So we don't want to give them a medication, especially if they're crying, they could choke on it, or if they're in a supine position. And typically, children under 5 cannot swallow pills. So keep that in mind. We need a firm, matter of fact developmental approach. You need to take this, especially if the parent agrees. It can't be a negotiation, right? Liquids, it'll be measured in a cup or a spoon by ml or milliliters, such as like an oral syringe, a dropper. You could use like little uh, nipples on the bottles or without the bottle. Um, for infants, this is a really important thing, is that if you're going to give them an oral medication, you need to insert it on the side of the mouth. Okay, and do not mix it with formula. So we're going to slowly insert, let's say like with a dropper or something of an oral medication on the side of their mouth. Okay. And remember, no mixing formula and food, and no mixing formula and meds. Okay, none of that. And if the child spits or vomits the medication, we need to notify the doctor. The last thing is the intramuscular administration, is that the needle length and gauge are based on the the child's size and the viscosity of the medication and how thick it is, right? So we want to use the smallest gauge possible that will effectively deposit the drug in the muscle. Know that, okay? We're using the smallest possible gauge. And there's different sites that we could use, but the primary sites are like the vatus lateralis or the thigh. This is the preferred sites for infants and toddlers until they can walk. So the ones that are not walking, they'll get any sort of IM injection in their thigh. The deltoid is when they're older than 1 years of age, such as like immunizations, if they have enough muscle mass present, and they're preferred for over 3 years of age. The ventrogluteal is another site, which is their hip, but they have to be walking to get this medication. Know these, know this, know this. Is like I said, the few things that I've seen she asked about is more or less about their organ systems and especially how to do IM administration. Okay. All right. The next chapter is chapter 36, and this is the comfort, pain assessment, and management. So, for developmental considerations, everything with pediatric is going to be developmental considerations, right? 1 month to 12 months, or an infant versus a toddler versus a preschooler. Every single age group has a different approach. That's why pediatrics could be hard because you need to know all of these different approaches, the age groups that relate to those approaches, and what is appropriate for that age group. Okay. So, when they're 1 to 12 months, we have behavioral indications. When we want to know they're in pain, they're going to tell us in two different ways, behavioral or physiological. Remember, they can't talk. So, facial expressions, such as eyes are closed tight, like they're squinting really hard, that's a sign that the baby could be in pain. Body movements, like they're shaking, the baby shaking, they're in pain. They had loud crying, that lets me know that this baby can be in pain. Physiological indicators would be vital signs such as tachycardia, tachypnea, oxygen saturation below 95% on room air, a breathing pattern that's altered, skin color, um, such as if it's molded or if it's pale and patterned, and pupillary size can also tell us if the baby is in pain. You will need to know this. You will definitely ask about this. Also, you need to know what are the normal vital signs for someone who is of which age group because the vital signs are also going to differ. So tachycardia in an infant is going to be different than tachycardia in your adolescent. So you need to know your vital signs for those age groups. Toddler is 1 to 3 years of age. So they're beginning to form words, but they cannot describe pain. Keep that in mind for a toddler. Remember, infants can't say anything. A toddler can form words, but they can't describe pain. So they can react to painful procedures and they can make something as like a little IM injection, like intensely painful. A toddler can over exaggerate it. So it also may be difficult for the toddlers to express pain, so they just cry when they're in pain. They'll have a variety of behaviors. They could have regression where they're like reverting back, you know, to like an older, younger state that's not appropriate for like their developmental age, right? They want to be cuddled or rolled into a ball. Um, and they'll use the word usually boo boo for pain. Remember, they can't describe pain, so they might cry and do other things. Preschoolers are ages 3 to 6, and they have magical thinking. So they believe that the pain that they're getting is like a punishment of some sort. But they'll tell you where it hurts, right? A toddler can't tell you. They're not going to be able to understand that. But a preschooler from 3 to 6, yeah, they could tell you where the pain is located, where it hurts. But they can't tell you the types of pain. So they could tell you they have pain. They could say, oh, it hurts here. I have, my arm hurts. And they could point to it, but they're not going to be able to distinguish types of pain. School-age children between 6 and 12 can. They could tell you the type, the location, and severity. They'll try to put up a brave front where they're acting like it doesn't hurt even if it does. They could have stalling behavior to try to not get the procedure right away. And we can use a numeric pain scale. We could say, if you could rate your pain from 0 to 10, 0 being no pain and 10 being a lot of pain, how much pain you're in. You can ask a 6 to 12-year-old that. The next group is adolescents, 12 to 18. Remember, these are adults, so we treat them as adults. We use a numeric pain scale, but they have body image issues, especially when they're in a hospital, so they're very more self-conscious, or they could become more self-conscious, and they also have a fear of losing control. And this results from, you know, denial of pain. They might refuse medications if peers are around because they don't want to look bad, so peers could influence them. And they also are scared to lose control, so they might try to say, "Oh, no, I'm okay. Nope, this is fine." And if we want to assess pain, a good assessment is called Quest. So it's a child developmental assessment, and parents, once again, always remember, parents can tell you what different cries mean, especially for toddlers and infants who can't express their words verbally as well. Crying will tell us a lot, but parents will know what that means. So, but we could use quests as a good way to have a generalized assessment for pain. And we can question the child depending on their age, right? Use a reliable and valid pain scale. Once again, toddlers and infants aren't going to use a numeric scale. Evaluate the child's behavior and physiologic changes to establish a baseline and determine the effectiveness of the intervention. That could be, like it says, looking for behavioral signs in the baby. Um, and signs that the pain's getting worse could be more increased irritability and withdrawal of the affected painful area. So maybe they don't touch it as much, right? We could do S, which is secure the parents' involvement. We always need the parents involved. T, to take the cause of pain into account when intervening, like what is causing the pain. And also we want to take action to resolve the pain. So that's a little quest, um, mnemonic. Pain management, we want to remember, we always talk about atraumatic care. We spoke about that before. So always, this is doing the least amount of invasive procedures as possible, right? Making sure there's safety measures in place, such as making sure they have a child's bed, um, and having safe spaces to go to. So for a child, right? Imagine you're having painful procedures all the time. You feel like everywhere you go, you're being bothered. Children need safe spaces, like a child's bed could be a safe space, a play area could be a safe space. And you'll see on pediatric units, if you haven't seen already, they have playrooms. So that could be after they got maybe their shots and they said, okay, we'll take you to the playroom now, and that could be like a reward. But if there's an emergency, they're not going to a safe place. They have to stay in the room. We want to offer choices. Like I said, they're especially important for those toddlers and preschoolers. We want to always allow parents to stay with the child because we said removing children from their parents would be traumatic, right? And we could use play therapy to explain procedures. Non-pharmacological interventions for pain management include distraction, right? So maybe you show a little demonstration and you're playing with a little teddy bear and you're having them play maybe while you do something like get medications, like draw labs or something. Breathing and relaxation techniques are another non-pharmacological intervention. We could also do things like pharmacologically, such as non-opioid analgesics if they have mild to moderate pain. That includes our NSAIDs or Tylenol. No aspirin. No aspirin. And these are first-line treatments. We don't want to go to opioids if we don't have to, but we'll give this for more moderate to severe pain, which is typically the same mindset for adults, right? Like Tylenol, NSAIDs for moderate to mild pain, moderate to severe, you give opioids. Um, the gold standard, the best one to give for a child if they need an opioid would be morphine. And we also want, if we're administering like these parental or epidural opioids, you always need to have naloxone, right? Narcan available because we need to reverse the side effects of the opioids if respiratory depression occurs. So if we're giving morphine, we need to monitor respirations, right? Because it can cause respiratory depression. You can't, even though that was a med surg thing, it doesn't change. If you know morphine, my first thing is, uh-oh, they're on morphine, I need to monitor respirations. Now, there's a chart in that I know she's told us to look at, which is the drug guide. It's 36.1 in your textbook, it should be. It's called Common Drugs for Pain Management. I would just read those over and know like what they are a bit, just so you have it. Um, I also added this in for developmental overview because this is something I know that was on my quiz. And the 5 stages or the ages is newborn to neonat, birth to 1 month, infant 1 month to 1 year, toddler 1 to 3 years, preschooler 3 to 6 years, school age 6 to 12, adolescent 12 to 18. Those are your um, age groups, so know them. And you also need to know Erskine's stages. She's going to ask about that, right? That in infancy, that they have trust versus mistrust, and that infants must develop trust. And you do that by getting or attending their needs right away. So when a baby cries and you attend them right away and you cuddle them and you coddle them and you figure out what's going on, you're helping develop trust. For toddlers, they go through autonomy versus shame and doubt. Toddlers want to be an individual, so they must get choices, okay? We want to give choices. They want to have autonomy. Preschoolers go through what we call initiative versus guilt. They're very dramatic, but they're also very social and they like to engage with other children. That's what this stage consists of. Industry versus inferiority. That's our school age children. That's our 6 to 12-year-olds, right? They're going to bring homework home from school. They're going to join activities and they want to be organized and they also want to be recognized for their achievements. Okay. So these are the type of kids, school age kids that are getting more involved. They're doing their homework. They're being more responsible, but they also want to show that if they get achievements, they want to be recognized for those. And adolescents are in this identity versus role confusing. They're just figuring out who they are. And that's a major thing when it comes to adolescents. That's why we do privacy and confidentiality and all of that stuff. Is there any questions? Okay.